So first of all, thank you very much, Professor Mohan Desai and Dr. Bagaria. Very well-packed audience. I think all the budding orthopedic surgeons and would-be arthroplasty surgeons are interested in this technology. So was the trend with the American Association of Hip and Knee Surgeons. Almost 70% of them, they would like to use that technology. So I use both the systems, image-based system and image-less system. uh, Image based is CUVIS and imageless is VELIS. So I think a very nice talk has been given by Professor Dhar about the imageless system. So we'll talk about my workflow or how I go about with the image based system. I think there is no doubt that it's like a pilot and autopilot. Robotic technology helps you to validate whatever you are doing during the surgery. So at the end of the surgery, you're convinced or you are yourself satisfied that the knee is well aligned and well balanced, as Dr. Bagaria had said. So it minimizes the margin of error. So it's like a plane landing at Mumbai airport. If the autopilot concurs with the pilot is very happy. If the weather is very bad, autopilot is showing something else, pilot will take over the control and land the plane himself. So again, I think you need to be a good conventional surgeon to have to be a good robotic surgeon. So the conventional surgery skills are always there and the concepts are always there, but the philosophy is different. So basically, it minimizes the margin of error, real-time guidance for intraoperative total knee arthroplasty, and accurate component size as well as positioning. That is also very important because so many of our conventional knees, we had notched, we had sort of our implants were small, our implants were big, the patients were not happy. They never used to, sometimes they never used to get adequate flexion, whatever you would achieve, would like to have in the post-operative period. So, this is the image-based system I use. It's simple. You can, I think they have displayed the system outside, so you can have your go and plan, or means you can use it on the sawbone model. Uh, so basically, it's bone preserving, accurate, safe. So this is the very, very early paper we wrote in 2022. 30 of our own cases, zero on-hand training, because I used to use navigation way back in 2011-12, and unfortunately later on the navigation machine was kept to dry the clothes in the hospital. That was the sorry state of affair in one of the hospital where I used to operate, in the corporate hospital. So, but again, I went to the sawbone, I observed certain surgeons outside Mumbai, and came back and I started planning my own sort of operations on the CT scan. In the image-based system, the patient goes for a CT scan. The 3D sort of hip, knee, ankle scan is done. Then those sort of files are segmented and brought back to you. Majority of the surgeons, they rely on the technicians. But I think my sort of word of piece of advice to the new surgeons, you plan your own surgery yourself, because I think you are going to do the operation during the day. So, and the beauty of image-based system is you are planning 2-3 days in advance. There is no pressure, there is no intimidation during the operation. Since I use both the systems, I can compare both the systems. So you plan it yourself, you develop your own algorithm and stick to it, and then execute it during the operation. So our very early cases, first 30 cases, we were almost 100% accurate as far as the femur was concerned, and almost 29 out of 30 cases we were accurate in the tibia. One of the tibia we had planned for, I think, 4, and we ended up putting 5. But otherwise, it gives you a very good idea of what implant you are going to use, how much cut you are going to do. So this we presented at an international level also, futuristic conferences like ISTA in US. So my intraoperative workflow, I'll just quickly run through the planning phase. See, this is the planning. The patient has got a CT scan done. The files are segmented. They have come to you on your robot. This is a typical varus knee. Now I am using a C implant. You need to know the thickness, posterior thickness of that implant. I usually stick that on the laptop itself. So size A is 7.2, size B is 7.7, size C is 8.2, size D is about 8.5, and so on. So since I am using a C implant, since it's a varus knee, we all know that in flexion, the varus knee is tight on the posteromedial side. So that's why my size C implant, I have kept the posterolateral resection as 8. Ideally, it can be 8.2. Now, depending on the very varus, I am cutting more on the posteromedial side. So traditionally, knee replacement was a soft tissue surgery. Majority of the times in conventional total knee, we were doing a combination of both soft tissue release and major resection, maybe 50-50%. Whereas robotic surgery is almost 85 to 90% major resection, and if required, 10 to 15% soft tissue release. So since I am cutting more on the posteromedial side, I know even though my gap is trapezoidal to begin with, if I cut more on the posteromedial side in flexion, it will become rectangle in a varus knee or a moderately varus knee. If it's a very bad varus knee, I may increase the gap between the two posterolateral and posteromedial resection. I may keep it about 2.5. Valgus knee, exactly opposite. If there is a valgus knee, I would like, if the implant is C, I would like to have a posteromedial resection as 8.2 and posterolateral resection as about 9.2 or 10.2. How you are going to do it? You are going to achieve that by rotating the implant. We just wrote a paper in the CUVIS. I think the 3-degree standard external rotation is not a acceptable norm for all the patients. In our first 100 cases, our external rotation in a varus knee was about 1.3 or 1.4 with respect to the TEA and about 2.1 to 2.2 with respect to the PCA. It was never close to the 3. So I think one size fit all is not correct. So in the varus knee, I want posteromedial to be bigger than the posterolateral, depending on the size of the implant, and in the valgus knee, exactly opposite. Again, posterior slope, I will go with a 0-degree mechanical alignment when I plan, but during the operation, as Dr. Vaibhav has very nicely said, certain negotiables, certain non-negotiables are there. I would sway from 177 to 183 degrees, but not beyond. I'll set a boundary of 2 or 3 degrees on either side, but not beyond, so that the knee will be well aligned and well balanced. So this we have already done before the operation. Okay. So once you go back, then very easy workflow I have devised. I am a PS surgeon, 100% PS surgeon. It has given good results in my hand, so I don't see any need to switch to the CR philosophy. I expose the knee in a routine manner. Initial few cases, we did not use a tourniquet because we were concerned about the time. We used to take almost about 20 minutes more. As the team matured, as our inflection, the the learning curve time was about 15 to 16 cases. The assistant and the surgical other people got used to it. We became time neutral. So only while implantation we used to use the tourniquet. Nowadays we use the tourniquet unless there is a contraindication for using a tourniquet in a particular patient. In image-based system, please don't remove the osteophytes. I think the natural tendency is when you expose the knee, immediately you take the nibbler, start nibbling the osteophytes. But because you have to register the tibia and femur there first, and because the CT scan has captured the osteophytes, please don't remove the osteophytes. Because what you are planning to do during the operation is you are planning to match the patient's anatomy with the CT scan anatomy, and there is something called as root mean square error. If it is less than 1, that means the patient's anatomy is matching with the CT morphed model, and you are good to go. You can attach the robot and the robot can cut with the millimeter precision. So don't remove the osteophytes. Traditionally, gone are the days that we remove the medial side up to the mid-coronal plane. Whatever is required medial sleeve, that only you remove to see the proximal tibia. Then you insert the femoral and tibial tracker pins. As I have told before, this is the only time I get little intimidated because this we never used to do it, but this is the new step which has been introduced for a robotic technology. Initially, we used to push the pins top up and top down. Nowadays, the femur pins, we are within the incision on the medial side. As Dr. Saraugi has very nicely said, I tell the assistant, I hold that zig myself. I always tell my assistant to just, as soon as he touches the opposite cortex, to stop. Instead of 4 cortices, I want to have purchasing only 3 cortices because it will minimize the chances of stress fracture. I never had one, but people had before, so you be very careful. The worst placement of the pin is transcortical, as he had said. Suppose if this is the cortex, the pin should be like this. It should be never at the tangent. And if you happen to do that, please protect that patient for first 6 to 8 weeks as a post-operative protocol. Then we put the basically pins. The aim is to prevent the transcortical insertion of the pins. So this is what we originally started. But nowadays we put the pins of the femur exactly on the medial side. So I operate from the lateral side of the patient. I put the pins on the medial side of the patient. The camera is there, and the robot will be coming from the lateral side of the patient. Bilateral knees, I don't operate from the same side. I remove the robot and I take the robot on the opposite side, because I always operate from the side where the patient is there. Right side, I'll operate from right side. Left knee, I operate from the left side. So then you register the femur and register the tibia. There are 40 points. Then there is something called as a crude RMSE and a final RMSE. The final RMSE should be something like less than 1. But again, if the patient has very bad osteophytes, if the patient has synovial chondromatosis with very large loose bodies, the RMSE can be acceptable up to 1.3, 1.4. If it is, it will show an orange zone in this particular system. If the RMSE is showing a red zone, please don't accept it. That means your patient's bone is not matching with the morphed CT scan bone. So ideal will be less than 1, acceptable up to 1.2, 1.3 if the patient has very bad osteophytes or loose bodies. Unacceptable is whenever if it shows red, don't accept it, re-register the tibia or re-register the femur, as whatever the case may be. Then what I do the pre-cut gap check. I have yet not removed the osteophytes. It is checked in full extension, 30, 60 and 90 degree of flexion. The medial and lateral gaps are captured. It gives a fair idea, as Dr. my previous speakers were saying, you have the gut feeling, once you remove that little medial osteophyte, it is going to open up by 2 or 3 millimeter. So again, you have to be a very good conventional surgeon, or you have to apply the knowledge of conventional technology and use it for the robotic technology also. So as you can see, I have, this is a varus knee. I have not touched any osteophytes, no tissue release. I have about medial gap at 90 degree flexion is about 7, lateral is 10. Since I am already going to cut 1.5 to 2 millimeter more from the posteromedial side than the posterolateral side, and if I remove the osteophytes, I am perfectly confident that this will become within the 1 millimeter sort of in the range. So I am good to go. I don't want to release any toss tissue. I will attach the robot, I'll cut the bones, I'll put the trial implants, again check the gap, and if required, then only I'll release the soft tissues. Now, anecdotally, the patients are telling us that one side we have done a normal knee, other side we have done a robotic knee, and at least the patients are telling us very, very early, no long-term data, no long-term PROMs, patient-reported outcome measures, but they say that this time their experience was better and the pain was less. Probably because the implants are fitting well, and probably because we are releasing the tissues less. Albeit there is a limitation, there is a bias of the patient that they have in their mind that they have got a robotic surgery. So that might be also playing on their mind, saying that their recovery was faster. So I don't know. It's too early. Time will tell when the 1 year, 2 year, 5 year, 7 year follow-ups will come and prompts will come. So this is what we have got to begin with. Then the CUVIS joint robot is attached to the patient. Previously, we used to do it by putting the 2 pins, one in the femur and one in the tibia. Now we have gone away with that. We use as Dr. Mohan Desai had showed in his talk, we use the clamps. So that decreases the surgical time of putting the pins, as well as the risk of stress riser close to the joint. Then the CUVIS joint robot is attached to the patient. So again, see, this is a side view, this is a top view. This is the center. RZ is the robot approach. RX is the flexion and extension of the knee. None of these values should be red. If it is red, it is not good. Then if you have a red RZ, you ask the company technician to change the path of the robot and approach the patient so that the red will be eliminated. If one of the RX is red, you slightly alter the flexion extension of the leg, then that redness will go, or the red alarm will go. If RY is red, then it is basically indicates the internal or external rotation of the leg. Either you adduct or abduct the leg, and you get that values, get the red sort of warning out of your picture. So we are ready to go. All the things are good. RZ, RX, RY. Side view and top view, both the femoral and tibial markers should be on the either side of the midline. Then you attach the robot and give the robot command to cut the bone. So femur cuts are done in following order. I am a PS surgeon, so I need to remove the box. Distal cut, anterior chamfer, anterior cut, posterior chamfer, posterior cut, lug holes, box cut, and trochlear cut. Probably this is only the robot which makes the box cut as well as the lug holes for yourself. See, this is what Dr. Mohan Desai has also said. These are the sort of early videos. You can see we used to put the pins, but now we have gone away. We have moved away from putting those pins to attach the robot to the patient. We use only the clamp to attach the robot. These are the pins to attach the robot to the patient. But now we don't do. Then tibia resection, medial condyle, lateral condyle, keel and keel wings. You can you can make a keel and keel wings with this particular robot, but I am little timid. I don't do that. I usually keep it to myself. I cut the upper tibial plane and then still try to adjust the rotation myself and use a manual instrument to use the keel and keel wings. So pre-cut gap balance is checked, post-cut back balance is checked in both flexion and extension. The trial implantation is carried out and the knee balance in flexion and extension, varus valgus alignment and flexion deformity hyperextension of the knee is checked. As I have told you, if it is tight on the medial side, then appropriate soft tissue release is done on the medial side in the varus knee to achieve a rectangular gap or near rectangular gap. If it is tight on the lateral side, then appropriate soft tissue release is done on the lateral side in a valgus knee to achieve a rectangular gap. My philosophy is, if this is there, okay. But in a varus knee, in extension, I want a little lateral laxity by 1 millimeter. And in flexion, I want a little lateral laxity by 1.5 to 2 millimeter. As Dr. Bagaria has shown, during the arthroscopy, we all know that the knee is little lax, natural knee is little lax on the lateral side. Again, there will be debate, there will be controversies, but this is my philosophy. In varus knee, in extension, I want equal gaps or maybe 1 millimeter lax on the lateral side. In a varus knee, in a flexion, I want about 1.5 to 2 millimeter laxity on the lateral side. So once I achieve that, I am happy. I close the wound once I go with the traditional. So these are certain very early cases which we have done. This is what the planning which I have shown for this particular patient. So these are the intraoperative pictures, full extension and alignment, postoperative X-ray. Again, very good advantage of a image-based system. You can take notice of that cyst which you have never seen on the X-ray. So preemptively you know that this cyst you need to graft during the operation. This is the cyst, grafted, postoperative X-ray. Patient from Jalgaon, he was managed conservatively 40 years back, fracture shaft of femur, extra-articular deformity, definitely a role of image-based robotics, scanogram, clinical picture, postoperative picture. Again, valgus knee. Traditionally, we were told that we need to release, otherwise there is a chance if you try to forcibly correct, then lateral popliteal nerve palsy, managed only with measured resection. Again, young, and this is the last case, young surgeon, I was assisting him, stress fracture on one side, very bad varus knee with robotic assisted stem extension. So I think this is the way usually I go with a image-based system. I thank you for your attention.